this week on the Backtable podcast.
I would make sure definitely that you do your research. You're knowing when, who, how, the right patient selection. You're talking to the guys that have done it before. And then, establishing those relationships, I'm going to say it again, are incredibly important. Those orthopedic guys, those sports medicine guys, those guys need to have your number. I've gone to the ERs, around and said, hey, if you get this, this, and this, you don't have to admit them overnight. I'm happy to see them in the clinic. Just making sure that you're definitely, you're marketing yourself as such to where you're available. Just make sure that you're doing the correct things. Don't just do a procedure just to do them. You're going to have bad results, and that's just going to haunt you from the get-go. Your skill set and your outcomes define you, so make sure you're doing damn good work from the get-go.
This is your host, Jacob Fleming, and with me today is a man of many talents and many names. Some have called him the Emperor. It's Dr. Ahmed Farag, good buddy of mine. Good to have you on the show.
Thanks for having me, man. Real honor. Dr. Fleming, what's good, man? So good to see you.
Good to see you too. We've been working on this a while. So actually, I think this is good to tell this story. So we first worked with each other on the SIR RFS, both during respective residency, and kind of known each other ever since, run into each other a few times. ISET 2021, I think. Good times. So it's just, I think, a testament to the kind of relationships across the country you make when you participate with the society stuff. And that's been honestly kind of unexpected to me. And we ran into each other recently at SIR, talked about some cool stuff. And we've been trying to make this discussion happen for a while, talking about musculoskeletal embolization in private practice. And so hearing about how this awesome stuff is actually implemented. So we'll dive right in. And why don't we start with just tell us a bit about your background, including your training, and where did you get started? How'd you get started with your interest in MSK Embos?
Absolutely. So my background is a little non-traditional. Medicine is actually my second career. I, in a previous life, was an engineer. So I got a bachelor and a master's in electrical and computer engineering, working on image processing and things like that. While I was writing my thesis in biomedical imaging, we were working with a bunch of radiologists, and one of them asked me to come shadow him. And this is way back before I knew what radiology, interventional radiology, any of that stuff was. And I remember we started off, he read a few images and he was like, hey, follow me. And he took me into the CT scanner and, we scrubbed in, and he just casually put a needle in someone's abdomen and got some fluid. Obviously now I knew that was, an abscess that he was draining, but it just blew my mind that this was even a thing, that a radiologist was doing this. So then I discovered interventional radiology, and obviously we did some cool procedures that day, and flash forward 14 years, here we are.
Wow, that's awesome. I actually didn't know that part of your background. So really cool.
So I did medical school at the University of Louisville, and then I did a surgical internship at Greenville, South Carolina. A wonderful surgical year, really, set the ground roads for everything. And I highly recommend any med student listening to this that wants to go into IR to strongly consider doing a surgical prelim year, just both for IR training and getting to know the lay of the land. Knowing that you want to live in a procedural-based specialty, you actually want to do it, that's going to lay the foundation for that. So that was tremendous. Came back to the Bluegrass Straight for radiology. And then after radiology, did my interventional radiology training in Baylor at Dallas, and worked with some really just top-notch people, I call them the masters of the field, guys like Jason Moss and Tom Seal and Chet Reese. And, those guys really laid the foundation for being both confident and competent. I got really lucky for Dr. Reese was, we'll talk about this later too, but he was one of the few people that was doing GAEs way back when. And, I always hear about, so-and-so say this technique is, the Amplats, bareback down. And I always laugh myself because Reese was doing it way before any of these guys were. So if you ever hear that, it's the Reese technique.
Awesome. Yeah. Shout out to all the faculty at Baylor, Dallas.
And, at the time I didn't really appreciate it because, you do a GAE and it's awesome. But in mind, you're thinking, I want to run out so I can, finish that awesome tips case and things like that. So while I was fortunate, I wish I would have appreciated a little bit more at the time. So coming out of training, that last year is kind of weird. You go through interviews and you're figuring out what you want to do with your life, right? And you quickly realize that most of the IR jobs out there, either you're doing academics, or if you want to do private practice, not all of them are doing high-end IR, which I knew I wanted to do. So I went on like 40 interviews my fellowship year, and a lot of them were the same, thora-para, read DR, repeat thora-para, read DR, thora-para, maybe align, then read some DR. So I wasn't really in the mood to go with any of those jobs. So I really wanted to get in a place that was private practice, but also did really high-end IR. So I went with a group that, it was one of those private practice, but, backed by the private equity guys. And so, the first few months we were doing really high-end cases. I do like a transplantic tips thrombectomy, things like that, a lot of embolization. So it was really wonderful. And then towards the end, and even before that, before we even got to the job, I forgot to say, credentialing is painful. So the job actually took like 6 months to credential. So I actually had some time in between where I did some locums work. And, I didn't just do random locums work. I actually targeted the locums that, they did high-end IR, stuff that maybe I didn't do as much of in fellowship. So, I went to South Texas and did a bunch of legs and went around and, got really comfortable with the things that, you knew how to do as a fellow, but you really wanted to get good at. And so I would, on a locums note, I would tell people like, you can really use that to both train yourself in stuff that you want to get better at. And you kind of have especially in the market today, you have the ability to go where you want. So I went to a place that had some really good partners that, they were, hey, yeah, you're just here temporarily, but we're still going to, treat you as one of us. And we're going to, make sure that we mentor you along the way. So that was really great. So back to the job, things are going good. We're a few months in, and this is where they start doing this thing that people had warned me about this, but I didn't think it was going to happen. Where all of a sudden it's like, hey, man, we need you to cover, these smaller hospitals for a few months. So you go from doing high-end IR at a transplant center to like, hey, now I'm doing those Thoras, Paris, and reading DR.
Yeah, right.
And they're like, oh, it's only be temporary. It's fine. And the next thing you know, that's kind of the norm. You'll get like 1 week out of 3 or, 1 out of 8. And, I could tell that that wasn't what I wanted to do. And, family things aside and whatever, we just decided to make a change. So I did the most powerful thing that you can do in your career, and that's put in your notice. So put in the notice, and then it was just an awesome time because 2 days later found out my wife was pregnant. So, I just quit my first job, found out my wife was pregnant, So we kind of went back to the things that we like doing. So I did some locums, and while we were doing that, we kind of advised like, hey, what's the end goal here? And I knew kind of, outpatient was, kind of the last frontier for us. So I did some locums in the OBL, but this was super fresh. They were just developing the program. So instead of just working we were actually developing the program and actually getting, something special off. And everything was going good. We started multiple programs. The GA program specifically was just super successful. Everything was going great. I was actually gearing up to move to Texas. And then about 2 weeks before we're moving, the gentleman, really nice guy, actually, he's a businessman. He calls me. He's like, hey, man, I'm selling the company. Okay. So now we're back to, at this point, the wife is, 8 months pregnant. The place I thought I was going to go to is no longer an option. So what do we do now? So we decided to just take some time off. We went and, hung out with some family in both Kentucky and Florida. From there, just kind of took a few months off. So while we were doing this, I was developing connections in the area. Seeing they were there. And, IR is hot pretty much anywhere you go. Help is needed all over. So, talked to the local hospitals, talked to some local physicians. And it turns out there was just both a big need, but also, this was just a comfortable spot. So while I'm, working with the hospitals, and, it wasn't locum at this point. At this point, we were true PRN. I was actually working with the hospitals. And, they're always going to want you to go full time. But I knew that going full time, the problem with that is they're going to make you sign a non-compete and you're not going to be able to do any of your outpatient endeavors. So we hunkered down there and we started with the hospitals. I was at the time still, interviewing with a few groups like, hey, maybe we're going to, work with, this person. There were a lot of wonderful people out there, but we ultimately decided the best move was just to sit tight. And about 4 or 5 months in, found out that, wife is pregnant with baby number 2. So then we're really now we're really, you know what? We're going to just pump the brakes.
Ante a little bit. Yeah.
We're going to pump the brakes and we're going to just kind of hang out in the area, hang out with his family and see what we can do. So we decided to go all in. Opened up our practice and, I had already made all the connections at this point. And, you met with a little skepticism at the same time, but I made sure that every consult I ever got, no matter how big, how small, didn't matter the time of day, they knew they could call me and I was there to help out. Anesthesia once called or the CT surgeon called and he was like, hey, anesthesia can't get a lumbar drain. Can you put this in? And I've never done that before, but, we need the general technique. So I went in there and helped him out. So point I'm trying to say is, just like Dr. Vatican Cherry always says, be available. So I really took that to heart, and that just made all the difference. So by the time we started going full-time outpatient, we already had like 200 consults lined up and ready to go. And so I'm already starting off like, man, I gotta kick into overdrive. And so we just put it all together, and it's been really wonderful.
Yeah. Wow. What an incredible story. And I think that's something that a lot of our listeners can relate to. I think it's something that's good for the younger trainees and students to hear as well, that you got to be willing to, depending on what you want, you may have to carve your own way to an extent. And it sounds like that's really what you've done. So you started off hot in more work than you probably knew what to do with. And then tell us about how you got started, specifically building the practice in MSK embolization. And, you'd obviously been doing a bunch of it in different avenues and different places. And so how would you say you approached the orthopedist specifically, and what were important wins to gain momentum in that part of the practice?
Yeah, absolutely. So I think the key differentiators, you got to ask yourself, what's going to be your main referral source? Are you gonna do most of it advertising? Are you gonna go out and kind of market yourself? How are you gonna build up your referral source? And you could do the direct to consumer model and things like that. But at the end of the day, your skills and your outcomes essentially dictate everything. Literally, if you do good work and you have good results, people are gonna come. So I started off going to some of the people around, the sports medicine doctors, orthopedic surgeons, things like that, and telling them what I was doing. And some were more receptive than the others. So we started getting in, more consults from the referral sources, and our results were just fantastic. And even the people that didn't believe in it. And here's the thing is, you're more of a humanitarian. A lot of these people are going to like, hey, Nana's knee is still hurting and you haven't been able to fix that. What other options do you have? Okay, well, knee replacement didn't do the job. Her knee's still hurting. So when they come see you and you're actually able to offer another alternative, or someone doesn't want surgery and you're able to offer an alternative, and now they're feeling great. They're able to lift up their shoulder. They're able to walk for the first time in forever. They can go to sleep for the first time in X number of years. That weighs heavy, and people are going to go and they're going to tell their friends about it. So, at the parks, at the churches, at the pool of, the physical therapists and things like that, those people are going to talk about it. So really using the people in the areas around there, I think the physical therapists and the sports medicine doctors and the orthopedists has been, they're starting to buy in, and they're also, looking like, hey, he's not a competitor, he's an ally. So once you get them to look from that way, it's synergistic at that point.
Awesome. And so you mentioned marketing. So tell us about, how you've gone about determining your market budget.
Oh man. So market budget, you know how much I spent on marketing?
I do.
Okay. I spent exactly $0 on market. I'm an interventional radiologist. I don't know how to get on. I don't even have a Facebook, right? I know that some of our patients, they write about it on theirs, but like I said, the best marketing you can do is to market your skills and do damn good work. Actually, I take that back. It's not zero. It's negative. I think Yelp, I have like a $300 credit, and Google, I have like a $500 credit. At some point, maybe I'll use that, but we haven't really gone down that road. Most of it is, like I said, has been the referral sources. I think, in smaller cities, especially, if they see something like that, the first thing they're going to do is go to their doctor and say, hey, Dr. Smith, what do you think about this procedure? And if he doesn't know about it or she doesn't know about it, they're going to say, yeah, I don't know about that. That sounds kind of weird, right? So getting into them from the get-go and just making yourself available. And, every day I'm talking to different people, or if I have time, my favorite thing is just to go roll on people, just go to a doctor and, go out the door. Hey man, how's it going? And then, for the first five minutes, talk about anything but medicine. And then give them a sheet with a few things that you do. Make sure you focus on a few of them. You don't want to overload them, but just say, hey, I'm the knee, hip, shoulder, prostate, fibroid, plantar fasciitis guy. I can do all those things, and I can do it, in a non-surgical way that makes them feel much better. And they'll remember that. And then, definitely talk to their, the PAs and the people around, because those are the people that send out the referrals. So once you get on their radar, and give them your cell phone, give everybody your cell phone. If they know they can call you for whatever the situation, even if it's, hey, can you just look over this imaging? Hey, can you look at this x-ray of whatever and tell me what you think? That goes a long way with these referral sources.
I agree. That's been my experience as well. And I echo what you said about getting in with the mid-level providers. some of the PAs, the physicians I work with are wonderful, and I'm kind of their go-to person for certain issues, which is cool. And you just keep that up and just build on those early successes, and it's a very natural way to build the practice, I think. And like you said, it's not necessary to go out and plaster your name on the billboards, obviously, but and to use that as a bit of an exaggeration. But getting started, like you said, it's all about your outcomes, and it's all about the 3 A's of being available, affable, and able.
Shout out to Dr. V. I'm telling you,
Shout out to Dr.
especially
V. Yep.
if you, these younger guys, especially if you take those mentors and all that, stuff you've heard when you were in the RFS and when you were still in residency, it really echoes. That model that he's been talking about for so long is so effective. And I think IRs, interventional radiology as a field, if we go that route, we will be successful. And if we do it together, we'll be even more successful.
Yeah, could not agree more with that. And so back to talking about building up the practice. So aside from GAE, you've been doing a lot of other less common embos. You mentioned plantar fasciitis. So how did you start to do those less common procedures? And the $1 million question is, the reimbursement aspect of it and making it financially viable in your practice. Just tell us about that journey so far.
Yeah, absolutely. I think we've had a lot of fun expanding the MSK embolizations just besides knee. Obviously these get trickier when you get to the smaller joints. Potential complications and implications are significant. So, if you want to start getting into that, make sure you start off slow. And if possible, you go out and see what the other guys are doing. If you guys ever want to come visit me, I'm happy to have you guys over here. I'll show you how to do these things. I think it's been really great because, these other procedures, the hips and the shoulders, people are coming back. I had a firefighter that couldn't lift his arm up for the last 5 years. And with a 45-minute shoulder embolization for adhesive capsulitis, he's now able to raise his hand. He's able to play basketball with these kids. These are life-changing procedures that are non-surgical. They're very, they're not time-consuming, and they're just very effective. I learned how to do this with very meticulous technique. Like I said, this is, again, where I'm thankful for the training back at Baylor and training with those guys, because, they give you the confidence, Interventional radiology, we're the field where we're trained, I'm going to quote Kavi on this, we're trained to take an embolic through a catheter and put it into an organ, right? So after, tedious research and things like that, and of course I told you I did GAEs and things like that back in training. So after tedious research and making sure, patient selection was right and going about, we started off slow, and, the results justified, expanding the project. You read what guys like Dr. Akuno and them are doing in Japan, and they've just, made it really easy to look and say, hey, this is doable. It works. Here's the data behind it. And the results are just spectacular. Funny story about Dr. Akuno, I met him, and, the first time I met him, it was like, it was like meeting a mix of like Michael Jordan, Tom Brady, Superman all in one. Very humble guy. I really, really appreciated making, and he's a good colleague, and, I really appreciate our collaboration. So you see what guys like these are doing, and they've made life, easier for guys like us. And the results, like I said, they're just spectacular. Now, reimbursement is a whole nother issue, and I'm not going to pretend to be the biller, but, my team here is kind of, we've kind of excelled and developed a really good algorithm. Your patients are your biggest advocate. If you're having good results, your patients are going to go back for you. So when patients come and they're automatically declined by the insurance, you only have so much admin time. So if you're having your team spend 80% of the day just calling insurances, you're never going to catch up. Get everyone involved, get the patients involved, get the patients, son-in-law, whoever involved. And they're calling the insurances like, hey, why are you not authorizing this procedure for Nana, right? Nana needs this procedure, and you're the reason that this is not happening. So, it may be a hard, long battle, but eventually you'll win it, and eventually they'll be able to get their procedure.
Well, that's awesome. And it helps to have a really tenacious team to go after it, and especially there's not necessarily a rule book. So hats off to you kind of coming up with your own algorithm for the team. It takes a lot of time. Like you said, it takes admin work, which I'm very familiar with right now. And as one of the unreimbursed things we do, admin work, it's an unfortunate part of what we do, but it's necessary. And that's how you build the flow of your practice that makes it sustainable. So, and speaking of making it happen, so tell us a little bit about what are some products that you favor, and in particular, in this area, having go-to catheters, microcatheters, and embolics is you got to have all those things in your toolkit. So tell us about that.
If you talk to 10 different IRs, they're going to tell you 10 different things. It's been my experience for the MSK embolizations that having a kind of, 45 degree, like, the glide burns, the glide caths and things like that are usually easier to work with, especially if you're going, pedal approaches and things like that for your GAE. And I think definitely, a swan neck microcatheter I use on just about every MSK procedure that I do. And then if you look at products, people are used to what they're used to in training. And to some degree, they're all equally garbage, some slightly less than others, except for Asahi. Asahi wires have always been good to me. So, if you're using like a Meister wire, that's, the Asahi of all wires, as I like to call it. Like a round curve with a swan neck for GAEs and for shoulders and hips and everything. I think that you can't go wrong with that. I do my hips from a pedal approach. And I think just having those curved catheters makes all the difference. Something that, guys don't know off the bat is when you talk to these product reps, they're going to come out and they're just going to give you a catalog and you think, oh, okay, I'll buy this, I'll buy that. Don't forget, you can negotiate. You can have more than one. The same catheter in the same shape is probably used at multiple different companies make it. So see what's out there. You can ask for a demo, but like, hey, can I try this product? Get the rep in there. Now you got to be careful with reps. Some of them, are great. Some of them not so great. Some of them are knowledgeable. Some of them are essentially just hyenas trying to get you to use their product. And, we all watch The Lion King. You got to avoid those hyenas, and also be careful too, because sometimes, I had a rep come in once and he was like, hey, I told this nephrologist, 40 miles away about, your GAEs and he wants to come learn how to do them. And I was like, I don't think you're gonna be here much longer. So, just a word of caution on who you let in, make sure they're people that are actually contributing to your practice. So yeah, the answer is use the stuff that's good, the stuff that, that you yourself are comfortable with and know that you can negotiate on it.
And tell us about your philosophy on samples.
So you can say you hear about something and you're like, this is wonderful, I want to try it out. You can ask the rep like, hey, I want to try your Uniglide or your Glide Wire Advantage, or, say, the guys in South Carolina love that Swift Ninja. If you want to try a Swift Ninja, ask them to use it. It may not be feasible to use that every day in an OBL setting, but at least you can give it a shot, right? They'll usually bring you a few products to sample. And I think it makes a big difference because then you can try it, game time, use the game time stuff that you want to use. And if you like it, great. If you don't, if you use something, caused a dissection, well, maybe that's not the best stuff to have in your OBL.
Sure.
But yeah, and it's a great way to just try it out. Same thing with products. If you want to try out a laser, you can, call the laser people and say, hey, I want to try this. They'll come give you a demo. There's nothing wrong with that. You don't want to throw, $20,000, $30,000 at a product, then you get in, you're like, wow, this is terrible. And you have to call them, the week later, say, hey, take this off my shelf, right?
Yeah, it's very, very different from being a primarily hospital-based interventional radiologist where you don't have to worry about that stuff so much. I mean, to a certain extent, you have to be making sure that the way you're practicing is sustainable, but even more so when you feel every dollar coming out of your pocket. And talking about outcomes like we did earlier, it's all about, does it work to get the job done? So try different things, try different brands and different devices and find what works for you.
Yeah, we all remember training where you had like 15, 16 wires out there and the attending's just throwing them at you, expecting, loop them up and things like that. That's not going to work in an OBL. So
yeah, you got to have your go-tos. And then speaking of go-tos, tell us about your choice of embolics, and do you feel that that's evolving with some of the newer options becoming available?
The embolics, I started off using Embazine for a lot of things. I switched to Embo Spears because I noticed I was having just slightly better results. Had a few colleagues that were having a few complications with other things, not necessarily Embazine, I'm just saying other things, but Embo Spears has been really good. And those resorbable embolics I think are fantastic. And if you look at the market, there's a lot of them that are coming, that are being created, I think are going to be out in the next year or two. So I'm really excited to see these new resorbable embolics that come out. But, for the most part, I'm using Embospheres or resorbable type. And, after you do a lot of these, you kind of get a feel with how much you need to put into whatever organ, how much blush, equivalates to whatever you want to put in there. But I would say for the most part, the Embosphere, especially for GAE, has been my go-to. And at some point I might switch that, but it's just really hard to switch up your starting lineup when you're on a win streak, you know?
Sure. Yeah. If it ain't broke. So talk about the other elements of your practice. You mentioned you had a patient get referred to you, did this ultrasound in the office, big DVT. You called over to the hospital, took them over and did thrombectomy, which is awesome. I mean, that aspect of being your own boss as far as that goes. And it's tricky because a lot of IRs don't have, it's not practical where they are because of local stuff. But the fact that you were able to do that, and probably that patient would have, gone in through the ER otherwise. And
if they went in, sometimes, exactly. Yeah. So yeah, I think, and this is where it comes back to having that good relationship for everybody. I highly, highly recommend you have a great relationship with your hospital. Don't just look at it like, hey, I'm an OBL, I'm on an island, I'm by myself. You need to have the ability, you have to have, privileges. You need to be able to go to that hospital, do cases, have it worked out where you're working with them synergistically. If they need help, help them out. If they need help with call coverage, you don't have to do it Q2, but help them out every now and then. So it's really great, that way, if I get something that I want to do at the hospital, whether it's a really complex, arterial case or a kypho or a DVT or a PE comes in, I have the ability to go to the hospital and just knock it out there. So, I have an, in-house ultrasonographer, which has been fantastic. It really, helps streamline what I'm trying to do. And, like you were alluding to, that patient that got, and this has happened several times actually, where I get called, they're like, hey, there's concern for a DVT. They come to me, we scan them, there's a big DVT. And then if I think it's appropriate, we take them to the hospital and do a thrombectomy. And then patient feels better. And then they see you in post-op, and they see you in clinic. And then sometimes that leads to additional things. I've had several, geniculars that came out of this when you tell them like, hey, I also do this, this, and that. And they're like, oh, wow, I didn't know that. And sometimes you need more conservative things, or send them to the other guys to get that conservative care first. But I think not saying no really helps out. If there's a liver biopsy that needs to be done, I'll do it. A lot of times that leads to a chemoembolization. Same thing with renal masses. We do cryoablations and ARF ablations, and all these things that, the guys want to say no to. If you have full comprehensive IR capabilities, you're really just making yourself more marketable, and you're able to keep all those skills up, and you can do all those wonderful cases that we love doing in fellowship and after.
That's amazing. I mean, I think for a lot of people listening, you've probably described kind of a dream setup. And obviously, anyone who's listened knows that doesn't come without a lot of effort.
Yeah, it's not
a
easy.
lot of stuff leading up to it, So it's very rare to just plop out a fellowship into, the so-called ideal aspect. And there's a lot, you highlighted how you're motivated to keep learning things and expanding your skill set from the get-go, and being open to different opportunities. It sounds like was really important for you, even though it sounds very stressful. Having trained and done my fellowship away from my family for 95% of the year, navigating around the family aspects of things and being present as a spouse and, parent and everything just complicates everything. But in the end, it sounds like you've gotten to a place where you're just killing it.
And it's a lot more fun now than it was, in the beginning. There was a lot of
Sure.
suffering that went in on this. And,
Yeah.
I'm very thankful for, all the mentors I had and all the advice I had early on. I can't imagine I've done any of this without that. And, I tell the guys that want to get into this, definitely make sure you have your mentors. You're asking the right question. And there's IRs out there, call your friends, see what they're doing. Come go visit them. You guys want to come visit me? Hey, come on down. We'll get you down here. We'll show you how to do some fun stuff.
Yeah, it's awesome. And one thing that I'll totally agree with that. I mean, just having good mentors who you can approach and about a tough case, or, about doing something that's maybe a little outside of the norm, and having the people, who say, it's not a crazy idea, well, here's maybe why that wouldn't work, that they're good enough to know, they'll tell you. But the corollary I've had to that is that bad advice is free. And usually given out freely. And so I feel like I've developed a pretty good barometer for when, someone's giving me bad advice. And it's not that they're trying to give bad advice. It's just that people are shaped by their experiences. And so just be aware, take that into consideration in terms of how that's informing their bias of what they're saying. And you get, you get a feel for this between everybody you meet, and knowing how their practice pattern is, what their history, have they had failures, or have they had certain successes, and what kind of challenges they gone up against. That's been really useful. And I mean, I semi-joke, not really joke, that on this podcast, I just bring people on that I want to pimp for career advice. And kind of, I mean, more so, I just enjoy this aspect
Yeah.
of it and getting to explore different ways of doing things. But, I'm pimping you, I've pimped everyone on the show and kind of taken the ideas that they've had. People have been successful in very different ways, and you get to choose what you want to do and what you don't do in terms of incorporating this advice. And so that's just one thing that I'll say is like, trust your gut and take time to kind of sharpen your filter for when you're getting good advice versus maybe someone is just not on the same wavelength as you, and they don't have the same type of goals. And so they wouldn't advise you the same way as a great mentor like Dr. V.
No, I totally agree with that. Dr. V has been instrumental. I call him quite frequently, Dr. V and Tom Seal. Those guys, they both gave me really good advice early on too. Jumping straight into if you talk to 80% of residents, IR fellows, they're all going to say, man, I'd really like to get an OBL. I think that really sounds awesome. But I also caution them too, hone your skills before you jump straight into it. Coming out of training, that first, G-tube or that first chole or what you do is going to be the scariest procedure you've ever done in your life, right? Definitely, cut your teeth, test your metal a little bit before you jump in and, get in with an IR, minded practice team, guys that have done, 1,000 PAEs, not just like one or two. Make sure you're comfortable with the scenarios at all acuity, because when you're in this OBL, especially, if you're by yourself, you're on an island, you get a perforation or you get a dissection or something like that. You're by yourself. You need to know what to do. So definitely have those guys on speed dial, but also make sure that you've, gone out and done a decent amount of practice. The second thing I want to, talk about, with that is advice is like, saving costs. You want to keep your costs to a minimum up front. All these things are not cheap, and, they require a lot of admin work, and a lot of these things can be difficult going on. So I definitely make sure, you establish a strong relationship with those vendors we talked about. Make sure you're getting the best prices, and make sure you don't just go crazy in there, because the worst thing is to go in, be 300,000-400,000 in the hole and then realize, oh, we're in trouble. I can't bill. I can't get patients on the table. I can't do this. Those are practice killers. So make sure you're asking the guys that have done this, and make sure you have a plan. While that's said, also make sure that you're getting the right advice. Like you were talking about, you can tell when you're getting bad advice. When I first started, we didn't really do any performas or, this or that. There was one company that said, hey, this is a really bad idea. You're in a terrible area. There's not enough people for this or that, and you're not going to succeed. And the truth is, they didn't know what they're talking about. If you have the drive and you go all in, you can make just about anything succeed. Obviously, you got to do it within the bounds of good taste, but just make sure you're also careful about your advice, like you said earlier.
For sure. And you've already answered a bunch of them, but any other pearls or pitfalls for IRs wanting to expand their MSK Embo practice specifically?
I would make sure definitely that you do your research. You're knowing when, who, how, the right patient selection. You're talking to the guys that have done it before. And then, establishing those relationships, I'm going to say it again, are incredibly important. Those orthopedic guys, those sports medicine guys, those guys need to have your number. I've gone into ERs, around and said, hey, if you get this, this, and this, you don't have to admit them overnight. I'm happy to see them in the clinic. Just making sure that you're definitely, you're marketing yourself as such to where you're available. And then the other thing is just make sure that you're doing the correct things. Don't just do a procedure just to do them. You're going to have bad results, and that's just going to haunt you from the get-go. Your skill set and your outcomes define you. So make sure you're doing damn good work from the get-go.
Well said. And so speaking of doing good work from the get-go, it's all about training. And like you said earlier, competence and confidence, both are necessary. And so speaking of that, is in regarding to this topic, are there trainings out there for people interested in doing more of this? You mentioned earlier that you like people to come visit your OBL, kind of see what you're doing. And what other types of things are available?
So yeah, the reps, I've noticed a lot of the device companies especially are trying to jump in and say, hey, we want to get in the embolization space. So there's a lot of trainings out there. I definitely, a lot of people don't like going to the conferences after training. I would highly recommend you go to those specific conferences, guest embolization, SIR, Viva. You're going to the ones where, the guys are doing all these crazy things and they're talking about it. Because I've learned so much just going like, oh, wow, that guy does it that way. Even though I've done 1,000 of this procedure, I still, get new things every day. that's just huge. Making sure you're keeping up with the time. There's a lot of exciting things that are coming out there, and just keeping up with the literature, keeping up with the techniques. I do think that students and residents and fellows, you can ask to go on a ways. You can ask to spend a week in an OBL. You can ask to, get out there and see what's going on. Even if it's like, hey, I'm going to take my vacation time and spend 2 days, you can ask to do that. And if you have a license and things like that, you can work it out to where you can get involved too. So I think we need to, as a specialty, make sure we're integrating that into training at an earlier stage, where people are saying, hey, this guy will let me come into his OBL. This guy will let me watch. Hey, this guy will, teach me how to do this stuff. I think that's going to make, aside from just the mentorship, but actually getting out and getting that exposure, seeing how people are doing it. 10 people are going to do it 10 different ways, but
yeah, and the 10 different ways is so important. It's so helpful to see things done different ways, especially early on when we're still malleable. And I couldn't agree more that, I think the training programs really need to try to integrate this newer paradigm of outpatient-based care. It's not necessarily a part of most training programs in a certain extent. I mean, yeah, we did outpatient work in residency, but it was all still hospital-based. So seeing this different aspect of practice, I think is so crucial. I was really fortunate that was kind of the environment that I trained in fellowship. And so seeing all these different aspects and, learning about practice building, kind of, how do they set up the practice to make it efficient and accomplish these things, and catheter and wire choice and stuff like that. So beneficial. So I think that would be great if the residency and fellowship training programs would expand on that a little bit. And
that's not rocket science what we're talking about. It's not interventional radiology.
It's not interventional radiology.
Get out there and see what's going on, and you guys, especially early on there, I think the guys would really appreciate it, because there's no question about it. This is the future. This is only going to get more popular. Any model, any study you look at, the results are just fantastic, and there's a lot of need out there. So many people are affected, and we're so fortunate to be in a field where when you see them in outpatient, follow-up, they're like, hey, I feel almost 100% better. I have 0 out of 10 pain. I'm no longer bleeding from my fibroids. I can now urinate at night after that PAE you did. We're in a field where we get that a lot of times instant gratification, and we're just going to further develop more techniques, especially for the MSK field, like we've been talking about for the last hour.
And speaking of that, what are you most excited about coming down the line?
Oh man, this is one of those questions that I love, and we kind of geek out just because there's so much to talk about. But especially when you read the guys that are doing this, across, and the guys that are our neighbors next door, they're doing all the small joints. I don't want to sound over dramatic, but I'm serious about that statement. I think our specialty allows us to accomplish treatments that are so different that they can save us from having to do surgical intervention, that we're able to do a lot of things through a pinhole incision that lasts for years. So I think we're going to do a lot more of the smaller joints, and you're going to see hand embolizations, embolizations of the ankle, embolization of the elbow, and you're already hearing about it, but it's going to be mainstream here soon. I keep thinking back, I did a GAE on a 96-year-old. She was told she's not a surgical candidate. She's going to have to live with the pain. Pain management couldn't do anything for her. She's just suffering, couldn't sleep at night. And literally after the GE, the next day, she's 0 out of 10 pain. So patient comes in and they're teary-eyed and they're telling like, hey, you changed my life. I was told I just had to live with this essentially until the end. And you've essentially made their quality of life so much better. So I'm very excited to see where, when, doing this on both a larger scale and doing this for the smaller joints. And, there's things that you see, the trials out there, and you hear about. Give another 1 or 2 years, they're going to be mainstream. So I'm very excited about that.
Very exciting all around. I agree. I love hearing about all the new stuff that's coming out, even though I don't specifically practice most of these therapies, but it's so cool to hear about how people in our specialty are thinking about doing things differently and integrated, kind of branching out into the whole patient population, into the massive MSK patient population that we can really help.
Who knows? Dr. Fleming might do one of the first, lumbar embolizations here. They come in with back pain and we usually just refer them out, but give it another 6 months, who knows what's going to happen. You heard it here first. All right.
You heard it here first. So speaking of hearing it from here first, I've gotten a lot of requests, a lot of people in the fandom wanting to know the origin of why they called you the emperor in fellowship.
So that was a nickname that kind of just, took a form of its own. It started off, so my co-fellow, Dr. Alan Heiss, fantastic guy. Literally one of the best human beings I've ever worked with. It's just so professional. One of those guys that you guys would fight over who goes home earlier. And it's not, the selfish reason. It's like, no, man, you should go. No, he's like, no, you should go. And it'd be like that. Literally, I had to beg him. I forget if it was Christmas or, whatever week of vacation. I was like, dude, just go be with your family. It's okay. So, we had to come up with a good way to do, the lists in the morning during fellowship. You present the list, who's going to go where, who's going to do what procedure. So we came up with a system, and I think it's a wonderful system. Anyone who's used it agrees, where if you're we call it the emperor of the week, you run the list with, the team in the morning, and you decide who goes where. So on your week, you decide which room you get, you decide which procedures, and that's it. There's no question about it. There's no argument. Everything's good. And next week, he was the emperor of the week. So really easy to do with a fantastic guy like Dr. Heiss. And that's kind of where that moniker came. And, just kind of, you heard it at the at SIR and ICE and things like that. But yeah, that's where that came from.
Awesome, man. Well, Ahmed, this has been a lot of fun. As always, I've learned a ton talking to you. I'm pumped to see everything that happens in the next few years, hoping to come visit you at some point soon as well. Any final words you'd like to share with our listeners before we sign off?
Yeah, we've kind of told you about MSK Embo. We cautioned you, but the thing is, if you guys are all in, there's a way to make this, and it's awesome. You can do the procedures you want to do. You can build the practice you want to build. You just have to go all in. Take the advice of your mentors and just get out there and learn how to do it. Go to the people that will teach you how to do it. It's incredible, and I really think this is the future. I think outpatient, especially for IR, you're only going to see that number go up. And, we need to go out there and we need to learn about what's going on in politics. You hear about these guys in OEIS and what they're trying to, lobby for. We really got to join that. I think we're so far behind on getting IR on the map. And if you ask any doctor, hey, what does interventional radiologist do? A lot of them don't know. If you say, hey, have you ever heard of a genicular artery embolization? These need to be mainstream names. So we got to do our part, and we got to go out there and we got to advertise ourselves as such, let them know all these awesome things we're doing. And, we got to have guys out there, the IR warriors, as Dr. V would say. We need the warriors out there to go take this field to the next step. So very excited for this. This is only the beginning, and I look forward. And, who knows, here in 3 months when they invite me back on the show, we'll give some updates. All right.
Well said, and great segue. We'll pencil you in for 3 months from now, and look forward to having you back. All right. Thanks, brother. This has been great.
Always a pleasure, my friend. Take care.
Take care. Thank you so much for listening. If you haven't already, be sure to follow, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at @Backtable MSK on Instagram, X, or LinkedIn. Backtable MSK is hosted by Jacob Fleming,
Michael Barraza,
and Chris Beck.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles, Josh McWhirter,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and show notes written by Marvi Espiritu
and Ann Dang.
Administrative support provided by Judy Dela Cruz.
Thanks again, and see you next time.